Does having dementia increase progression of hearing loss?
There's no evidence of that. In fact, the evidence would sort of show the other way around, although you can't show cause, but we certainly know that the two are related to each other. But the way that the research is tending to look is that hearing loss or untreated hearing loss is a factor in the development of dementia, as opposed to the other way around. So Danielle already introduced who I was, and she talked a little about what I've been doing for the last 30 some years. I did go back to school in 2008 to 2010 and do my Doctor of Audiology program, but I've continued to be a clinical audiologist, and that's my love, meeting with patients every day and learning about what their needs are and finding creative solutions to help them. So let's just sort of jump in. I'm going to thank you for coming. I already said that. That's all about me. We already talked about that. What I want to talk about tonight is the relationship between hearing loss and the development of cognitive decline or dementia or Alzheimer's, all the different words you want to put to it. What we know is that there's a strong relationship. There's been some very interesting research come out in the last 4 years from the Lancet, which is the British medical journal, and from Johns Hopkins Hospital in the US. And I'm going to talk about those things tonight because there's a strong relationship. And the good thing is it's practical things that we can do to help reduce or slow down the processes of cognitive decline. One of the things that the article in the Lancet brought out in 2017 is that the symptoms of cognitive decline show up later in life, but the underlying brain pathology develops many years earlier. And that piece of research looked at all the potential modifiable risk factors that we're aware of. And what that showed is that it might, that with those modifiable risk factors, there might be up to 1/3 of the cases of dementia that could be slowed down or prevented, in fact. And here's what they look like. Early in life, education. So we know that early education, people who have more education early in life are less likely to develop cognitive decline. That's not something we can do a lot about now. That's when we were children. In midlife, the factors were hearing loss, hypertension or high blood pressure, and obesity. Later in life, smoking, social isolation, which we heard a lot about from Dr. Hand, depression, physical inactivity, which she also mentioned in her talk about social isolation, and diabetes. This is the little diagram that they put up about the potentially modifiable risk factors. About 65% of factors, I'm going to, if you see at the bottom of this, are things we can't do anything about. Those are our genetics. Those are the way we're built. There's the things we can't do anything about. But here it shows that early education, less education it accounts for about 8% of the modifiable risk factors. Hearing loss at 9%, hypertension at 2%, obesity at 1%. Late in life, smoking is 5%, depression 4%, physical inactivity 3%, social isolation 2%, and diabetes 1%. So there are about 35% of the things that we know are related to cognitive decline are things that we can potentially do something about. This is just a blow up of that, so you can see that a little bit better. I broke it down here. Hearing loss accounts for about 9% of those factors, smoking 5%, depression 4%, physical inactivity 3%, and social isolation 2%. Those are the major ones. That accounts for about 23% of the modifiable risk factors that we have. Back in 1980s or late 70s, when I was in school in learning to be an audiologist, we knew back then that individuals with hearing loss suffered from social isolation. They suffered from depression, paranoia, and reduced physical activity. We knew those things, but we really didn't have a lot of other research to point us on where those things were coming from. What we know now is that of hearing loss, which accounts for about 9% of those modifiable risk factors, but we know that hearing loss leads to depression and social isolation and physical inactivity. That's another 19%. So it means that almost 18% of dementia cases could be eliminated, reduced, or delayed significantly by treating hearing loss early in midlife. That means that treating even mild hearing loss is now strongly indicated. What that means is what we're telling family physicians out there is when people hit 50, it's time to send them to have a hearing assessment to find out where their hearing is. If it's normal, that's great. We've got a baseline to work with. If there's hearing loss beginning to show up, early treatment helps, gives us much better long-term outcomes in terms of our hearing and slowing down the effects of cognitive decline. All human brains become smaller as we get older. It's accelerated in people with hearing loss. We know that from research and studies looking at people's brains. Untreated hearing loss may result in serious long-term consequences to healthy brain function. That shows up in the research from Johns Hopkins medicine. One of the things that we know, we think, well, why is this? Why is it that hearing loss affects our brain? Why is it that it leads to cognitive decline? The biggest issue, or one of them, the biggest ones, is cognitive overload. And what that means is when we begin to have trouble with our hearing, understanding language becomes difficult. People speak and we hear them, but we're not always sure what they've said. So our brain has to work extra hard to figure things out. So we're looking at contextual cues. What did we just finish talking about? What are we likely to talk about next? And then making good guesses about that. But it also means things of, is it a sunny or a cloudy day? Did a dog just walk past us? Did someone just spill their coffee? All of those things, those extraneous things, help to give us cues to make good guesses when we haven't heard the words clearly. But that uses a lot of cognitive resources. So our brain gets overloaded trying to figure out what people are saying. That cognitive overload starts to use up resources that used to be used for other things, and particularly having to do with memory. So people will come away from a social engagement saying, boy, I'm exhausted from that. It was really hard work just to be there and to listen and understand what people are saying. But over time, that cognitive overload starts to rewire our brain. And areas that used to be used for other things are now being used to help with language. And so that leads to often trouble with short-term memory issues. The other thing that happens is social isolation. And this ties in very directly with what Dr. Hand was saying. When we don't hear well, we begin to slowly drop out of doing things, not because we want to, but because, well, when I go to play bridge, I really can't hear what the other people are bidding. And so, I'm going to stop going to play bridge, or I don't go to church anymore because I can't hear what the priest or the minister is saying. I don't really like to go to family gatherings because when I go there, I can't follow what's going on. So I just sit in a chair and nobody talks to me because I can't follow. Those are sad things, but they happen because of not hearing well. People begin to drop out of social interactions, which is all part of social isolation. It's a really significant factor, and something that, again, something we can do something about to keep people engaged. We know from research that people with untreated hearing loss are up to 5 times more likely to develop dementia. That's a big amount. That's a big factor. And if we can improve that by treating people's hearing loss with appropriate hearing devices or other rehabilitative methods, then that's a really good thing. 5 times is a big difference. And if we can improve that, it's one thing that's going to make a big difference in people's lives. What it means is that people who are 50 plus should have their hearing checked regularly. We want to be on top of it. Or starting early treatment is the best thing we can do to improve cognitive, to improve the chances of reducing the risks of cognitive decline. People often say, well, goodness, I'm 85 years old. Should I do something about my hearing now? And of course, the answer is yes. It's sort of like the question about when's the best time to plant a tree. Well, 20 years ago was the best time, but the next best time is today. It's never too late. And in fact, there's some interesting research happening at the University of Melbourne right now. And their preliminary research is suggesting that not only does treating hearing loss slow down the progression of cognitive decline, but it actually can reverse it. And they're showing some improvement in cognitive performance after people have been treated with appropriate hearing devices and are using them on a regular basis. The good thing is about getting your hearing assessed is it's easy. There's nothing difficult about a hearing test. It doesn't cost anything to have a hearing test done. There's no commitment about it, and it'll help you to understand where you're at this moment. And it gives us a baseline to work with for the future so that we can monitor at appropriate times so that when the right time comes to do something about hearing loss, we can be on top of that. There's something else I was leading to there, and it just slipped out of my mind right now. I guess one of the things I was saying, as part of our assessments at True Hearing Health, we provide a cognitive screening at our office. It's a little computerized game, really, that you play. We're the only place in Canada to have this technology. It's an FDA-approved cognitive screening tool. You play a little game on a computer, and it helps us to know about your short-term memory, executive function, your processing speed, reaction time, and your visual spatial skills. It takes about 10 minutes, and it's not something that's administered by a person. It's administered by the computer, so it's always done the same. The retest reliability is excellent with it, and it gives us, again, a window of where people are at cognitively. That helps us. If we see significant issues there, then of course we're going to refer back to your family doctor and say it would be appropriate to do more extensive cognitive testing for this person. But the other thing that it helps me with is developing an appropriate hearing treatment plan in the way that we set the hearing devices based on where the challenges are with their cognitive function at that time. So it's an important piece of the pie that we incorporate into our processes at True Hearing Health. Let me just move down here one page. That's our phone number, but remember it's 1135 Adelaide Street North. So we're just north of Huron Street on Adelaide, on the west side of Adelaide Street. I'm open to any questions that anybody might have. It's something that I'm passionate about. I've been doing this for, well, too many years. My wife keeps saying, don't say how many years you've been doing it. They're going to think you're an old man who doesn't know anything. But I've been doing this for 35 years or so. So I'm passionate about helping people with their hearing, and particularly in the last few years when we've really seen how important hearing health is to our cognitive health as well. It's just something that I'm passionate about, and I love to help people and love to interact with people all the time.